Good afternoon, everyone. My name is Kim Stevenson, and I'm Director of Workforce and Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Violence in Healthcare, Making Strides for Safer Environments. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2026 annual sponsors and strategic partners for their support in underwriting today's webinar. This is just one of many events we offer throughout the year to connect our members with leading experts to help address timely issues like the one today. I'm pleased to introduce our speakers. I will be moderating the discussion with Christi Barney, Vice President of Quality and Patient Safety and Chief Health Equity Officer at Emerson Health, and Brendan Riley, Director of Security, Parking, and Transportation, and Chairperson of the Workplace Violence Prevention Program at Leahy Hospital and Medical Center. Massachusetts' journey to improve safety and reduce violence in healthcare is not new. It has been and continues to be one of MHA's top priorities each year. While those involved directly in this work are intimately familiar with the efforts to prevent and reduce violence and the data trends, we thought it was important to share our work with a broader audience today. So thank you for being here for this update on this critical work. So as I'm sure is not new to anyone watching this webinar, there has been an increasing trend of violence. Here's just a handful of headlines that I picked out last week. Nationwide, especially in the post-pandemic era, people are short-tempered, and things are getting more complicated with patient care. Throughput is challenging. So the next slide, please. There's been a lot of calls to help to reduce violence and prevent violence. On the next slide, we put out a landmark report in 2023. This was the first time that MHA publicly talked about violence in healthcare and the rising of incidents of violence. And we put out a lot of publicity around this report. This is the first time that we shared the data that we had been collecting for a number of years publicly. And we have been working on this for quite a long time. On the next slide, I'd just like to, in one more, thank you. I'd just like to talk through our journey at MHA. We've been at this for over 9 years now. We started our workplace violence prevention, safety and violence prevention work group back in 2017. And I'm not going to read through all of these elements, but you can see the work that has been done over the last several years, including working on legislation to address violence in healthcare and make it a felony to assault healthcare workers. We've published multiple documents on guidelines for preventing violence and improving safety in healthcare settings. We started our data collection journey back in 2019, and we collect data from our member hospitals on a monthly basis, and then annually we issue reports to key leaders of each hospital, comparing their data to the statewide data. We have a Caring for the Caregiver task force, which looks at safety as one of the four pillars of that work, and often provide education, both virtual and in person, related to this work. We've held a summit every year for the last several years. I'm sure many of you have attended at least one of those. On the next slide, you can see our more recent effort. Again, most of this is just continuation between the data collection. In 2023, we issued that report that I mentioned, and our Board of Trustees unanimously voted to adopt a united set of principles for Patient and Visitor Code of Conduct, which we'll get to in a little bit. There's been a lot of public advocacy with the legislation. We've been trying each and every year to get legislation passed, and we'll talk more about that again in a little bit. But just wanted to show the breadth of the work that is already being done across the state. Some of you might be aware of all of this, and this might be new to some of you. On the next slide, I just want to talk a little bit more about the work group. Christi and Brendan, who are joining me today to talk through our work, are our co-chairs for this work. You may notice that they come from very different perspectives, clinical and security, and that is intentional. One of the pillars of this group is how interdisciplinary it is. And you can see just a subset of the disciplines that are represented on this work group. And we certainly recognize that it takes all of us coming together to address this. We all have different ideas, different experiences, different training, biases, etc. So it's really important to look at this from a holistic, multidisciplinary angle. If you go to the next slide, we have over 100 members on this work group from our hospitals. Many hospitals have multiple people from different areas, from risk management to clinical security. And overall, the goals are to address the issues, to share best practices, to share strategies, challenges, solutions. And you can, again, see some of the key efforts. Some of these I highlighted in the timeline, but we're really very proud of the work that we've done. This is something where Massachusetts is really a national leader in this work. We've started before other states did. Our data collection process is really quite evolved, which Christy's going to talk more about. And we've been happy to share our work with other states through AHA. And from now, I want to invite Christy to come on screen, and she's going to start and talk about the data. Thank you,
Thanks,
Christy.
Kim. Thanks. So, as we begin this section where we're talking a little bit about data, that certainly has been one of the efforts that this group has been able to leverage the power of aggregate data from all the different hospitals to really understand the scope, the depth, the breadth of workplace violence in our healthcare facilities. But we always begin any of our meetings by really acknowledging that while we're talking about numbers, those numbers are people. And first and foremost, I think for all of us who are involved in this work, and certainly I think all of us in healthcare, when we talk about workplace violence, it's exceptionally personal. We are talking about our friends, our colleagues, our coworkers, people that we stand shoulder to shoulder with and try to provide the very best care for patients. And so to know that this data represents those same people ending up emotionally or physically harmed in some way, I think pains us deeply. That's why this matters so much to us. Getting it right matters a ton to us. So we always acknowledge that and acknowledge that just even this subject can be very triggering for people. And we always want to make sure that people, just be thoughtful about that. So even as we're talking about this today, please take good care of yourself as we're talking about the impacts of workplace violence. We start by hopefully some of you have heard of this quote before: the plural of anecdote is not data. That means that just because two people told you something happened, that doesn't demonstrate a trend. And this is really hard when it comes to episodes where we're talking about workplace violence, because there's often a buzz about the event. And so trying to understand how many people were actually impacted. Are we talking about multiple similar events, or is this just several versions of one story? That becomes a really important piece of this. And we know that this becomes important as well because all of us are prone to just cognitive biases. And so there's something called recency bias, where the last really unfortunate, bad, difficult thing that happened is going to be more front of mind than maybe a longer trend. And so we want to make sure that we're using data in a thoughtful way to help drive decisions. There's also outcome bias. We certainly sometimes focus on kind of the worst situations, but we may be missing the day-to-day smaller events, such as, for example, verbal abuse, which can take a terrible toll on many of our frontline staff and the folks who do registration and work at information desks, and may not have the same kind of headline power that, say, a physical violence event might take, but we know that it actually has a huge toll on them. So on the next slide, you'll see, when we began to work on this, we really wanted to sort of encompass all of it. We wanted to make sure that we were really getting a good look at all these different ways that we understand violence and make sure that our data was reflecting that. And so we developed some guidance on how are we going to collect this data. We began monthly data collection. It was voluntary. We went through several iterations, and then we began to have hospitals de-identify their data, but begin to submit. And that actually started before 2019. 2019 was when we were really able to then begin to share that aggregated data after we had been collecting it for a little bit of time. And over time, we certainly have changed. On the next slide, you'll see that, you know, again, we've published some documents, but we've also spent time. We have a data subcommittee, and we've wrestled with how are we going to report this? How do we understand it? What are the key variables that we wanted to make sure we were collecting so that we truly could understand the data that we were seeing? And on the next slide, you'll see that one of the things that at one point we did was we polled members and said, well, what are your sources for getting workplace violence reporting material? And we found, you know, this varies a lot depending on your particular organization. So in some organizations, say risk management collects this data. In other places, it's your quality, your patient safety, your incident reporting system that might have the most data. But we were also aware that, for example, security reports have a richness of data, and OC Health, Employee Health, HR may also have some data. And so one of the best practices we've really identified for our members is that the most robust way to do data is if you do a crosswalk. So for example, here at Emerson, once a month, we pull all of the health reports, all the security reports, and all the safety incident reports, and we crosswalk them. We want to make sure that we're not missing any kind of data that is out there. We want to make sure that for every incident, if we have multiple perspectives, such as security and incident reporting, that we put those together so that we have the best perspective on the incidents that happen. And that's really what we would encourage as all of you who are listening today are thinking about your own data. Make sure you're not missing any sources so that we again are getting the best possible data we can. On the next slide, you'll see, you know, over time, as we've been collecting this data, what's unfortunately been true is that violence is increasing. So as we started, an incident occurred every 57 minutes. And, you know, now our more recent data suggests that every 38 minutes. Now, this is all kinds of incidents. So this includes everything, again, from those physical violence events to verbal disrespect, verbal abuse, threats. So it really runs the gamut of all of those things. And we are trying to be as broad as possible because we know that all of those have impact, again, on the teams that take care of patients. On the next slide, you'll see that this is our most recent data in 2025. So certainly still within our data, the largest bucket remains completed physical assault. We think that's in part because it does take time to do reporting. And one of the unfortunate bias that we're kind of working against is that I think there still are many in the workforce who unfortunately think that some amount of verbal or physical abuse is sort of, quote, part of the job. And we've been working really hard to change that perception that that's not okay. And so encouraging people to pause and let us know the other kinds of violence that are the precursor to those physical events is really important. And that's how you get it into the data, by making sure that it's easy and that it's actionable. We also wanted to understand who was being impacted. So again, far and away, we see nurses and security officers are the top two reported groups of impact, but we certainly have everybody else. We do think that some of this may be subject, again, to who does the reports. So, you know, there's always a question of whether or not we've really fully captured all of the information, but certainly we know that nurses and security officers are on sort of the tip of the spear when we're talking about workplace violence in many, many situations. On the next slide, we've also spent some time really thinking about where does this occur? And again, each of these, this is the aggregated data of all of those hospitals. The other important thing that I think we can all learn is that our own data may look different than this. So again, depending on the robustness of the different sources that you're pulling to find out, because again, self-report, I could see in the chat somebody was referring to self-report. That's not the only way, again, right? If we have security reports, I may actually have observers and responders who are giving me more data about the other impacted people than I would get if I just relied on people to report by themselves. So the sometimes chart review yields additional incidents, and then you can dig deeper and find the people that are impacted. Similarly, location-wise, the data would suggest that the emergency department is the area where the most events happen and are reported. And we know that inpatient units, again, may be subject to some underreporting in some systems. So that's another area where, again, depending on your institution, you may have to work harder to make sure you get that. One of the things that we've seen more and more in our data are the outpatient and off-campus locations. So that's an area where we've spent some time both in our fall retreat and certainly in our ongoing committee meetings, thinking about how do you equip the teams that work in some of those offsite locations where the resources may be different than an on-campus location, and where the skills are slightly different, where a lot of the interaction that again may be difficult may be verbal interactions. And so have we really equipped all of those, as I was saying before, patient access, registration, people who do phone triage, have we made sure that they have all the skills they need in order to take good care of themselves and set appropriate limits when needed with patients? So the data gets us part of the way, but a lot of what we've learned is really around how do we then leverage that data and begin to use that around training and strategic initiatives. And for that, I turn back to Brendan.
Hi, good afternoon, everybody. I'm Brendan Riley. It's really my pleasure to be part of the program today. I just joined in this leadership capacity, co-chairing with Christi earlier this year, following the great Bonnie Michaelman, who recently retired as the vice president of Mass General Brigham's security program and had led this from the security perspective from the very beginning. So we certainly owe a big debt of gratitude for Bonnie being such a trailblazer in this work, and certainly big shoes for me to fill as I move forward as a security leader for this healthcare safety and violence prevention work group. So now, as Christi teed us up, we have this knowledge that empowers us through the data collection. Where are the solutions? Where are going to be our focuses moving forward? Next slide, please. So we have really surveyed our member hospitals over the years to really identify what have been the top initiatives, particularly around education and training. And this has been the feedback that we've seen consistently from the members over the years, a real emphasis on de-escalation, really creating that reporting culture, also implementing systems and technology and engineering, environmental controls is possible, and standing up some of these other features as well and these other priority areas here. And I imagine this looks pretty familiar and pretty consistent to a lot of folks that are on today's call of some of the focus areas up to this point. Next slide, please. So one thing we're talking more and more amongst each other in our work group is some new approaches that are really emerging nationally and regionally and locally that seem to be quite effective, and the data is informing us that, and the research that continues to come up, particularly the effectiveness of behavioral emergency response teams and crisis response teams. We're seeing more organizations really formalize that, really not only as a real-time activated team during a crisis, but perhaps more importantly, a group to provide consultation to whoever the primary team is that's going to be caring for and managing this patient as they continue to be in the organization's care. And some of the key members of this call upon administrative nursing, leadership, consult, psychiatry, providers, of course, public safety, supervision, and other key members, particularly those that have an expertise on navigating behavioral challenges and solutions. So very often, I know from my past experience, when we've been able to have some of our hospital medicine providers lean on to the consult psychiatry service to assist them on prescribing of medications that might be appropriate for the continuation of this care, particularly in a med-surg environment. It can be really a difference maker after we've had the onset of a crisis incident. How do we try to prevent and mitigate as we move forward? And these teams have really emerged as a real value add for the organizations that have invested in them and have that capability across, 24/7, 365. We know often these events could occur on overnights and on weekends. So it is a heavy lift. It is a big undertaking, but certainly something that so many organizations have realized great value on. And really the emergence of more and more trauma-informed care, of how we focus on how we communicate with folks who present to us in crisis and have behaviors of concern. I learned many years ago, and I was fortunate to often approach these individuals in crisis with two vantage points: assume good and assume trauma. And that really helped me personally, but also with our public safety and security professionals, really to guide us in how we can effectively communicate with people in crisis in a manner that still reflects our core values as caregiver, really empathy and compassion being at the center of that. And also being aware, are there any common triggers that we've identified that really seem to be impetus for escalating behavior? I'll give you an example. We had an individual in our care coming from a local group home who only seems to have risk behavior in our laboratory when they're having blood work done. That really seems to be a flashpoint for them. And some of the group home staff members, despite their best intentions, haven't been able to help our caregivers. And we've had phlebotomists battered by this patient. So we've identified that as a trigger and we've taken a more holistic approach. We've pulled in public safety to really support. And, now that patient is being handled with due care that prioritizes not only her safety, but also the caregivers when they're going through those type of encounters. So there's a lot of power that comes from having that awareness and knowledge and communication across different elements of care, because otherwise that patient has phenomenal behavior when they receive episodes of care from us. It's really that one trigger that we've identified and we've addressed, like I said, that prioritizes patient and caregiver safety. We're seeing an emergence of a lot of patients that are managed through telehealth, and sometimes it's the stressor of coming into the hospital or into the healthcare facility that could lead to agitation and aggression. So sometimes we're seeing folks appropriately cared for the use of telehealth that's more convenient for them and it has been really effective. And the use of flags and appropriate care plans for patients that have a past history of violent behavior. I firmly believe that the past is the best indicator of the future. Every new encounter is a new encounter. However, I think there's power in making sure caregivers are fully informed of past incidents of violences, completely, rather for, in particular, completed physical assaults, having that level of awareness, and most importantly, what is the actionable guidance? What is the plan? What measures can we take to prioritize our personal safety? Again, we go into that encounter without judgment, but well prepared to prioritize our personal safety, and flags can be very effective in doing that. I think we've all realized over the years that we have to have a very objective, unbiased process, and that's one thing our work group is really focused on over the years is health equity relative to the management of workplace violence. So that really factors in. So having that oversight of that thoughtful flag process and being very selective and objective and unbiased is critically important. And population specific education, we often hear de-escalation thrown out there as an umbrella term, but that really looks quite different relative to the approach, the tactics and techniques based on different patient populations. And for all that big data set, we ask for a contributing factor when one is identified for violence events. So you're looking at nearly 14,000 incidents that are reported in. And when a contributing factor is identified, we're seeing well over 50% of the time it is a clinical factor. So what pops to the front of my mind is how do we communicate effectively with patients experiencing delirium superimposed on dementia? What are those communication strategies and those de-escalation tactics and techniques as opposed to an adult who's acutely intoxicated in alcohol in our emergency department, as opposed to a child with autism that's having a meltdown in our care? So I think the more and more we focus on population specific and we lean into experts that have a lot of experience and specialization working with different populations of patients, we're going to see us become more effective with our approach. Next, please. So security risk assessments and threat assessments are also a cornerstone part of the solution as we move forward. And here's a number of examples you can read through on our slide. They're really focused on engineering controls and administrative controls, emerging technology that we utilize here across the spectrum of the type of violence that we can encounter in the healthcare space. And it really often starts for the security folks with crime prevention through environmental design, how we can try to manage criminal intent violence. And a lot of these other safeguards are focused on a type 2 violence or that patient client generated violence. Also, what are we doing about lateral violence, incivility, and bullying amongst our workforce? And then personal relationships outside of the workplace that could impact, with some of the highest impact violent events when they do occur on the hospital campus, and also ideological violence and extremist violence, that new emerging type 5 violence. We all have to have plans for all of that. So hopefully all of our organizations, when we come together as workplace violence prevention committees and councils and work groups, we're looking at our current state of things. We're assessing through a critical eye what is our current state across these different spectrums and where we have the opportunity to partner to administrate through policies and procedures and protocols. Are we getting the voice of our patient through a PFAC or other community guidance? And what is our current state of things relative to our engineering controls that are in place in the different systems? And most of all, theme of today is that effective data collection. Are we getting an accurate capture of our violent events and where they're occurring and what we can do move forward? Next, please.
I'm going to join you here, Brendan, because this is, as you just teed up so nicely, so much of this hinges on good data. And as Brendan was saying, if we do a good job with data capture, we begin to see the population. So some of what our work group has done is really, again, tap into the areas where we have experts across the state in terms of dealing with particular populations of patients, and then try to leverage that so that we all learn from each other. Having a standard response once a workplace violence event is reported is extremely important because it builds trust with the staff that are dealing with situations every single day. So again, our ideal standard response includes, if you are going to take the time to tell us something through reporting, we want to make sure that certain things happen as a result. So making sure that then we take that information and escalate it for every time, as Brendan so nicely said, the past pattern of behavior is the best predictor of future behavior. So if I know that a patient has already crossed a line and exhibited one of the many forms of workplace violence, that is a highly likely thing to repeat itself unless I have enough interventions in place. So we want to use early warning signals and really understand, do I have all the care and treatment around this patient that I absolutely need? Do I need any specialized care? Have there maybe been a behavioral health consult? Do I have other kind of environmental modifications that need to happen? So often our members describe reporting triggering a discussion in either a local unit huddle, but also the organizational safety huddle so that there's situational awareness and additional resources. That data also becomes that source, as Brendan was saying, for the creation of flags or care plans, things that can live on and help guide teams moving forward. But the other really important thing that helps trigger is this making sure that we're layering in taking care of the people who are impacted. And so one of the ways that we use our data here at Emerson, and I think many of the organizations do, is to make sure that for every single one of those reports, I try to understand the people who are directly impacted. If we can put a name to that, then we can layer in help and support for that person. So again, many places have follow-up with the local department leaders, with the staff leaders, the senior leaders. Here at Emerson, that has a sort of multi-layered process. And one of the really practical things we do is I write a letter to a quick email to every single person who's impacted. I give them my cell phone number. They have an opportunity to check in with me. We make sure as well that they're handed a handout that tells them easily how to get a hold of EAP, peer support, that they understand how they would report if they wanted to report this to law enforcement. And many of the organizations, again, we've borrowed from each other in creating these kinds of processes. And you just want to make sure that, again, as a standard way that we react, we want to make sure that we're meeting our staff through this and that we're walking alongside them as much as possible. We often can't take away the thing that happened, but we can make sure that they're not alone. And that counts for a whole lot. So again, having these standard things worked in really allows us to do a good job of understanding. Again, in certain situations, we absolutely need, the whole department may need critical incident stress debriefing, or may need an opportunity for EAP to be available for some period of multiple shifts, again, depending on the event. Or it may be that that one person needs an ongoing dialogue with OC Health, or with EAP, or peer support, or emotional support resources of many different flavors. So figuring out how we do this piece, this is the why report. And once this is hardwired in an organization, the reporting often increases because people begin to tie together. When I put this down on paper, I'm both creating a pathway to prevent this from happening to other peers, and I make sure that I'm going to get the help and support that I need after having gone through this. I'm going to turn it back over again to Brenda to talk a little more about one of the exciting things this group does is really, again, state level advocacy and some of the legislative work. Take it away.
Thank you, Christy, and thank you, by the way, everybody that's been posing questions in the chat. And again, we welcome you to do so, and we'll certainly engage with those great questions later on in the presentation. But for now, let's talk just briefly about some of the state level advocacy and legislation. Next, please. So one thing for those who've been really involved with the MHA's work group over the years, an important milestone for us was to come together and craft a member hospital united code of conduct principles document that has gone out to all the member hospitals here and really created a great opportunity for us for consistency. You know, of course, Massachusetts healthcare is incredibly competitive, but I found united we stand across all of our organizations when it comes to management of workplace violence. So the more we can be consistent with developing these expectations and messaging them out and being aligned across organizations, there's really value to that. I'll just give you our case study example here where I work. We adopted the code of conduct principles as you see them. The only thing we customized, the last section, the maintenance of code of conduct, Roman numeral number 3, we just added specific language about what our reporting mechanism is here locally. Otherwise, this was adopted unchanged at our organization. Next, please. And we've received really great feedback from the members after this was implemented. It was messaged out, and a lot of Massachusetts hospitals ended up implementing locally. And this is the survey results. So clearly, it had an impact of staff members feeling more supported, which is a really great benefit and really helped clarify expectations. There certainly was feedback that there could be some pushback about this. I do think when you go into these really difficult conversations, and by the way, I do believe the conversation is most important. It's critically important and valuable to have it in writing to fall back on. But sometimes when it comes to relationship building with an individual who's acted out in our care or their family member, really trying to rebuild that relationship through the difficult conversation, but then also having the clearly stated in writing requirements to fall back on is really valuable. However, oftentimes people's human nature, you're signing yourself up for a grievance, that your patient relations is going to get a call, and people can be very defensive in nature, and now they're going to want to make a formal complaint or a grievance about how they are treated. So part of this is what can you expect from us, and what do we require of this relationship from you? But clearly, the feedback here is by and large positive and very enlightening. Next. And speaking about United We Stand, incredibly proud of our Commonwealth of Massachusetts, and all these stakeholders, which don't always align, are in total alignment when it comes to the pending legislation, which passed unanimously from our Massachusetts House of Representatives back in November and now rests with our Senate. And we remain optimistic in the hopes that this will be passed by our Senate before the close of the current session. So just a little bit of the highlights here. One of the big ones here is empowering caregivers who choose to report acts of violence to be able to utilize their employer or their labor union's address during the initial court filings. Because I've certainly seen in my career, and I'm sure relatable to many of us, where there was apprehension about wanting to provide personal information to report that you have been subjected to violence in your healthcare job. So we've seen this in other states, is really been an effective way for getting better reporting and having people feel more comfortable about making that connection to local law enforcement to report the violence that's occurred. Some of the other key points here to make is the understanding that these acts have to be com completed knowingly and intentionally, and to result in bodily injury, really to rise to that felony level, the more significant legal penalties for it. So absolutely, this should have a great impact, and other states have realized that, but certainly other states have also seen there are populations of patients that are not going to be legally culpable because they don't meet that knowingly and intentionally standard. So I think we will have an opportunity when this does pass to do some level setting for expectation here, but we're convinced this will prevent acts of violence and it will hold individuals accountable that harm caregivers. But there are certainly going to be folks that are not going to be subjected to the penalties based on different factors. So certainly much more to come. And if you have questions about this, certainly tap into any members of the MHA and the MHA Healthcare Safety and Violence Prevention Work Group. Next. And I'm going to turn it back over to my colleague, Christy. Thanks.
Thanks, Brendan. So one of the things we wanted to make sure to share with all of you today, some of you may already be familiar with this, but on the next slide, you'll see that one of the other big focus areas for our group has been to take all of this best practice that we can see across the Commonwealth and develop some guidance. And in this way, Massachusetts is really leading the nation, first of all, in having a standard data collection, to have a data set like this through partnership with MHA every year. For those participating in our data collection, we can then create true benchmarks for the other hospitals so that we can use the other data that MHA has available and understand the rate at which violence is happening in different institutions, and really get a sense of, again, how we stand with our peers. We also tried to pull all of this best practice guidance that we had developed, and we initially created this document. And then on the next slide, you'll see more recently, we've done revised guidelines. And I believe the QR code there will actually directly take you to a copy of that. We really wanted to make sure, as the difference in those few short years there between 2019 and 2025 included our growth, both as a group, but I think our growth in the Commonwealth, really thinking holistically about this subject and patients. And we really wanted to make sure that we were reflecting a health equity framework. And so you'll see that throughout the new guidance document. We talked more about these additional care settings. Early on, I think there was a tendency to just focus on the hospitals, the sort of traditional hospital setting, and less data collection and less understanding of the needs of ambulatory sites, off sites, home health sites. So really understanding again the full breadth of healthcare in 2025. You heard Brendan earlier refer to special populations. So again, that's reflected somewhat in the new updated guidelines. And it's one of the areas, again, where we've really tried to leverage the best practice that happens at different organizations so that we're really learning from each other. We also wanted to make sure that we were keeping up to date with the new published Joint Commission Workplace Violence Prevention Standards. So again, our work had actually already aligned very nicely with what then became the Joint Commission standards, but we wanted to make sure that that was reflective in our documentation. And we leaned into trauma-informed care and made sure that this revised document really reflected that as an important principle. And then talked again about the support for both victims and the focus on workforce well-being. So all of those things are seen in the guide. And on the next slide, you'll see, again, I won't belabor this, but we really tried to think about sort of pillars of healthcare violence prevention efforts. So you've heard us sort of touch very lightly on these subjects today, really the importance of support truly from the leadership on down, that there's a sense that this is a crisis and that this is something that we need to do something about, that there's education and training, that we use the data collection to help us inform how we're delivering care and how we begin to understand patients. This is, I know in the chat, we'll circle back to this later, but this idea of how do we get ahead of it? We would ideally like to have the ability to predict who's maybe going to have the hardest time or where workplace violence would happen so that we can get ahead of that. And again, some of our members have already used some of the standardized tools. And so we've learned from the hospitals and healthcare settings that have implemented the proactive workplace violence analysis tools and implemented those in developing care plans to try to proactively get ahead of violence that happens in the workplace. And then making sure that, again, we really integrate all of the work and the data collection. One of the most important things we can do is use our own individual data to leverage the interventions that need to be done in our own setting. All of us are in resource constrained environments. So, if we had unlimited time and money, we could do everything under the sun, but instead we're often trying to figure out where should we spend the most time in training for our teams? Where do we need environmental controls? And it's really important that we invest heavily in those solutions. And our data can actually tell us that. It can tell us if we need extra security on the second shift or again, more cameras in a particular area, or it might say we need more emotional help and support. And so we have to think about how we're resourcing our EAP and our peer support processes in each of our hospitals. And then finally, we used this, again, this aggregated data. If you go on to the next slide, we went through sort of multiple rounds. we tried to take the best of all of it and all of our our fall retreats and the experts that we had gathered, and really, again, used subject matter experts and went through multiple rounds of edits. So our hope is that you'll take a peek at the guidelines, use them. Some of the hospitals have really used them as a point to sort of crosswalk what you're doing locally and try to figure out if there are gaps or risk points in your organization, and then lean into those places to build an even more robust prevention strategy for the future. I'm going to, at this point, turn it back to Kim, who's going to help us wind up.
Thank you, Christi, and thank you, Brendan, as well. The points that we really want to hit home on is that probably one of the most important is the multidisciplinary collaboration. It's so critical. I'm sure that you have heard just from what Christi and Brendan talked through how important it is. This really needs to be everybody coming together to address this. It can't be solved by just one department. And to address a comment in the chat about prevention, I completely agree. Strategies and training are absolutely best aimed at preventing incidents of violence from happening in the first place. But having said that, there also needs to be training to react to these situations, unfortunately, because probably some level is inevitable. Not to say that it's okay or justifiable, but unfortunately, just the nature of people and stress and stressful encounters. Data collection has really been our beacon of light. We started this many years ago. As Christi went through, we've revised our survey. There's some questions in the chat around data that I definitely want to get to. Really great questions. But you can't know if you're improving or getting worse or what's happening if you're not actually looking at the data. So I know all of our hospitals are collecting and reporting this to us, but it's really important to be reviewing that data internally as well. I know Brendan at Leahy does a lot of great work. They go all the way up to their board talking about the data. So if your hospital isn't doing that, that might be something that you want to consider or talk about. And finally, you're not alone. We're all in this together. One of the really great things about our work group, as Brendan mentioned, though, there's a lot of competition between systems and hospitals and such, not in this area. We meet regularly. And we're very candid and open about the challenges, the solutions, and sharing and helping each other. We all want everybody to succeed in this space. So it's not there's not really shouldn't be any gatekeeping on solutions and strategies and such. I know our members are very forthcoming with what they're doing, where they're having issues, and sharing with others. Oh, what worked great at my facility is this. Maybe you could try that. And there's been some individual conversations across hospitals that I know. So you're not alone. We are working to address this, and maybe someday webinars like this won't be needed. So I'd love to invite Christi and Brendan back. We have a lot of questions in the chat. If you have questions, please put them in. There's been some really great commentary and questions that I would love to get to. I'm going to kind of go back to the beginning. Christi, I know you addressed this a little bit already, but workplace violence is self-reported. It's not uncommon for facilities with better reporting structure and more transparent and more robust support for staff to see a rise in violence as efforts are rolled out. That's one thing that we've discussed a lot in our work group is an increase in violence reported an increase of reporting or an increase of violence. And can you talk a little bit about how we've looked at that and tried to standardize that data through, against patient days, patient visits, and also looking at the consistent cohort of hospitals?
Yes, great question. Thank you for that. And I think that one of the important things that we spend some time talking with our members about, particularly before the annual report goes out, is that we all have to be good data stewards. So 100% yes. When we get better at reporting, the numbers of violence events will go up. We know even with the most robust reporting, we probably are still getting drastically underreported the events that happen during the day. Particularly, I think, as we touched on earlier, that there's a rise in just general incivility and verbal abuse and inappropriate comments. And so, as we get better at capturing this, the very nature of it, we will start to see rise. One of the nice things we've been able to see in our aggregated data, though, is that over time, what we see is, again, both locally and then, when we look at the bigger broad data of the collective hospitals, that we see a rise in verbal abuse and threats and a decrease in the physical completed assaults. That would suggest that we have been able to a little bit get ahead of this so that Brendan talked about the importance of de-escalation training, that as we get better equipped to deal with these difficult situations, diffuse, contain, redirect, set limits, that we're able to intervene in such a way that it doesn't end up in a completed physical assault. And so I think often what we're doing is trying to tell that data story again, and a lot of this is looking at your individual hospital as well as the larger story in Massachusetts, and trying to use the data in a way that helps you understand where you need to go next. I hope I explained that well.
Yeah, thank you. And related, can you talk about the work of the data submitters group to make sure that they're not, if an incident might be a single incident could be reported to different departments and such, how that's being reconciled so that it's not getting counted multiple times in the reporting to MHA?
Sure. Yeah. Again, this has been, I guess, for those of us who love data so much, this is the fun part. We try to find ways, and so the actual way that the report is constructed allows the data submitters to help clarify that. Ideally, you are representing one event. Now, it may impact multiple people, so there's that one event, and then the multiple people would be represented in each of the data submissions. We have a pretty low-key process. We're working on enhancing that with a new data portal for some, I believe it's now in RedCap versus an Excel platform, but it's pretty straightforward. And some of this, again, is we have to be good data stewards, so you have to do a little bit of babysitting of your own data to make sure that, again, it's that you're not double counting. On the other hand, as I said, in our data, we might have one patient who's responsible, even in one event, for impacts to multiple persons. That we also capture when one patient has multiple events over time. And that for many of our organizations, I'm sure Brendan can reflect on this, sometimes those are the patients that, again, we're really trying to get our hands around when we know we've had multiple aggressive events happen over time, and we have to really implement our best practices there to try to contain that patient so that over time we're able to get ahead of that person ending up physically harming staff, multiple shifts.
And there are many organizations that have moved towards just one source of truth. Oftentimes, an enterprise-wide safety reporting solution is the one platform to report incidents like this, that security, employee health, everybody goes into that central report despite any other work that they have to do. So there are a lot of organizations that progress that level to just get that as accurate as possible data capture.
Thank you. And switching gears a little bit, Christi and Brendan, I know this is something that we've talked about in our work group. I know it's something that we did incorporate into the revised guidelines. Can you talk about the role of PFACs? So, and for those that don't know, PFAC is a Patient Family Advisory Council. Every hospital in Massachusetts has one. Can you talk about the role of PFACs in helping to reduce workplace violence and how individual hospital committees might work with their local PFACs on this issue?
So, I can take it a little bit, and then I'd love to, I want to make sure that Brendan can chime in as well. The PFACs, so have a bunch of different roles. So for starters, we always present our annual workplace violence aggregated data and our plan to our PFAC because honestly, what was really interesting was that the many of the members of the public are still surprised to learn actually about the level of workplace violence going on in the hospital. I think surprisingly, people sometimes are still agnostic to the level of daily strain that the team is under. So it's a useful beginning point to just say this does exist. Certainly, when we rolled out like the code of conduct, when we do any of the discussions about how we're going to message this, we have a patient partnership agreement, for example. Using your PFAC can be a great litmus test to get, again, the sort of public's impressions of how does this work, the language that we put, particularly in written things. So our PFAC has been great about giving us that kind of feedback and actually helping us think about some of how we message certain things. That's been one of the really wonderful things that the PFAC was able to do.
Thanks, Christy. Brendan, anything to add?
Just it helps to get the patient and family member perspective. And again, I agree with Christy that oftentimes they're not aware of the volume and severity that the workforce is facing, but they also provide invaluable perspective. Let's face it, for systemic reasons outside of our control, there's a lot of resentment towards caregivers right now. And I think every PFAC member's had a bad experience. They've had unmet expectations. They maybe have said or done something that they were emotionally not in a good place that is regrettable. So it helps us go back to our caregivers and say, our goal here is not punitive in nature. That doesn't align with our values. Our goal is to provide for another chance for that patient or family member to come back from that bad behavior with really clear expectations of how we require them to behave and the respectful relationship between caregiver, patient, and family member. So getting that outside perspective also helps our teams.
Thank you. And gosh, I hope I'm going to get to all the questions. There was one question about thoughts on home care and the different challenges that home care workers face. And yes, we did actually reach out to Home Care Alliance as we were drafting the new guidelines. And so there is a small section there about home care. Colleen Pirro, I'll give you a quick shout out, was great to help us with that. So check out the guidelines. I definitely understand it's a much different setting than your typical acute care or ambulatory setting. And Christine, Brendan, I'm not sure if you have any thoughts specific to home care, but definitely a challenging environment where you don't always know what you're stepping into and who you're going to be interacting with.
And I don't think we could do it justice in our 3 minutes remaining, but this is an area that's coming up. We have our summit every year, and it's going to be in November. We're hoping to have a special presentation that day that's really aimed at home care and the unique challenges there.
Thanks, Brendan.
Yeah, and I would just, again, I think the same principle has to apply. One of the things we're finding in some of these ambulatory and offsite locations, as well as home care, is making sure people feel empowered that if they feel unsafe, that can be the end of the interaction with the patient. And I think getting around, yes, we're trying to be flexible. Yes, we're in sometimes an area with less resources. It becomes even more important to make sure that our staff know that we will back them if they need to end the encounter for safety reasons.
Thank you. Um, and gosh, a couple more, two questions we'll do real quick. There's a question around surprise that in our data, there's not more incidents happening outside of the hospital, like in parking lots and such. Is it because national data could be focused on serious events, whereas we're including all severity levels, or do we have a lack of reporting in those areas, or have we figured out the magic where we're just not seeing a lot of incidents in those spaces?
And there's recently the Healthcare Violence Project put out a 25-year snapshot from 2000 to 2024 that was really focused on shootings occurring across all of U.S. healthcare, and that found 33% of the shootings happened in the grounds, the parking lot or the parking garage.
Wow.
So absolutely, when it comes to extreme violence, that has been the trend that we've seen from that data. But locally, fortunately, we have not had a lot of those tragic type of incidents. But it has to be a layer of your violence prevention and mitigation program, focusing on your parking garage and your parking lots and your protective measures there.
And this is where that local data matters so much. As Brennan's pointing out, when you look at the national data, they're considering all different kinds of settings. There are definitely differences between our member hospitals in different parts of the state, whether you're in an urban environment, whether you're in a more remote, and that there would be violence possibility in both, but the mitigation strategies you might have might be very different in those two settings.
Thanks. And one final question. I know we're at time. Are there any learnings or frameworks used to track and care for multi-visit patients across care settings that can be adopted around patients or visitors that have engaged in multiple incidents of workplace violence?
I think this is often where we're seeing institutions using those patient partnership agreements, flags, care plans, where you identify a real pattern of problematic behavior, and then you work proactively with the patient to reset expectations and to understand the circumstances under which that person does their best, actually, and navigates healthcare without any incidents to try to set it up for success. And it's usually some combination of those different tools and the investment of some time to proactively make a plan that appears to have the best success in most of the organizations.
Thank you, Christy. And thank you everyone who attended today. Really appreciate all of the questions and the engagement. We are going to have our HSVP Summit on November 12th. It's not on our website yet, but check back soon. It will be there. You can see some other upcoming events that we have. And if you scan the QR codes, you can go to our events page where everything is listed out. Really appreciate all the engagement and you all coming. Slides and the recording will be sent to all registrants, so watch your email boxes for that, and we'll include the recent guidelines with that as well. Thanks, everybody. Thank you, Kristen and Brendan. Always appreciate your collaboration on this. Take
Thank
care,
you.
everybody.